Good morning from San Donato.
Very welcome this morning.
Thank you so much. Welcome from San Donato. I'm Francesco Bedogni, as the chief of the adult cardiology in San Donato Hospital. Working with me, Federico De Marco and Nedi Brambilla, as two really very experienced in structural heart disease in adult. Today, there is a lot of people this morning, despite the fact that yesterday we had a very nice evening and night, but we are here to work from 7 since 7 o'clock. Federico De Marco will show you the case today.
Okay, good morning everybody. So the next case is a valve-in-valve. It's a mitral valve-in-valve for a failed mitral valve bioprosthesis. Next slide, please. So the patient we are treating is a 73 years old female. She had the rheumatic heart disease since her childhood. She is hypertensive, dyslipidemia, and permanent atrial fibrillation. In September 2016, she underwent double valve replacement, and she received the Hancock 29 millimeters bioprosthesis in the mitral position and the Hancock 23 in the aortic position. She felt really well for a while after the intervention. She had no more dyspnea. She was in New York class 1 for a while. But after less than 2 years from her surgery, she started again to be symptomatic, and she worsened up to New York class 3 with some exercise symptoms. Next slide, please. So she underwent again evaluation. I don't have, unfortunately, any images to show that the bioprosthesis in the aortic position is working well, but she had a really a degeneration of the bioprosthesis in the mitral position, and the intervals in surgery is quite short, but anyway, you see also from the transesophageal echo that the leaflets are very restricted in their movement. On the image on the left, 3D also shows that there is some restriction in the movement, and the gradient across the valve is around 15 millimeters of mercury. Next slide, please. She underwent a CT scan, also which showed some degeneration of her leaflets. Also, we evaluated an area of the residual area of the mitral valve, which is 0.6 centimeters, which indexed for her body surface gives a very narrowed area. Next slide, please. So the plan is to implant a Sapient 326 millimeter valve inside her Hancock 229. The true ID of the Hancock 2 is 24 millimeters. So a filled 26 should be okay. So we started the procedure. So we accessed the femoral vein. We did the transeptal puncture. We crossed the valve, and that's the stage where we are at. We can show you images of the procedure.
Okay. If there is some question about the case, the indication, we are ready to answer. If not, I will show you what we have done until now. Thank you so much. So now we started with the transeptal puncture. I think you can see the screen, okay? Yes, with the transesophageal echo guidance done by Maurizio Tusa, is the chief of the echocardiography in our hospital. And so we go ahead. Next. Okay, we cross without problem the septum with a broken needle and okay, go ahead, avanti. Next.
Could I just ask about the location of the puncture or the mitral?
Yeah, perfect. It's quite similar to it's quite similar to mitral clip procedures, posterior and superior, to have room to engage the mitral valve. So it's the same puncture side of the mitral clip procedure. Yeah. Okay.
Thank you.
Go next. So we cross the aortic to have a pressure in a left ventricle. Perfect.
Yeah, we
Then-
confirm the invasive gradient to be around 15 millimeters of mercury. Next.
So this is the confirmed stenosis. So then we dilate the interatrial septum to have a room to cross with our sheath in to go to the left atrium. We use a 14 balloon size, 14 French balloon. So this is the 14 millimeters balloon. Sorry. Vai avanti. Next. After that, next.
What wire do you have?
Yeah, I think we'll get to that. If you want to see in a second what we did, actually it was not easy to cross the valve. Next.
Yeah, now we started with the Amplatz. We tried to cross the valve with the guiding catheter, a 6 French guiding catheter JL4, but it was very difficult to have enough support to cross with our catheter. Next. This is the most difficult part of the procedure. We tried with the Terumo wire. Next. Then we decide to next. Well, you know, we had every time we had a prolapse. It was difficult to cross, and when we cross with the Terumo wire, we had the prolapse of our guiding catheter in the left atrium. Vai avanti. Next. Gira abbastanza. Yeah. Next. So we decide to place an Agilis catheter. Is the flexible catheter, that used usually in electrophysiology. This is the flexible tip catheter. Vai avanti. Next. Well, you have to find the correct. You will see we are deflecting the catheter to cross. Next. Ancora. Avanti. Then we could place our guiding catheter in the left ventricle through the Agilis. Next. Then we place next again. A stiff wire, an Amplatz extra stiff wire. Next, and parallel to the Amplatz stiff wire, we place a Safari wire. There's a pre-shaped wire used for aortic intervention. Now we have two stiff wire to support our procedure in a left ventricle, a Safari wire. Then we decide to pre-dilate again the septum because it's possible that you have a recoil of the septum, so it will be might be difficult to recross. So we post-dilate again the septum, and now we are ready to go with the Sapien 3 26 in Hancock 29 to implant to do a valve-in-valve procedure.
So we decided to use a double wire technique, which, you know, the second one wire is used to deliver the valve, the second wire is used, as a body wire to ease valve crossing and septal crossing.
And when we cross the valve, we will remove the body wire and we maintain the other stiff wire to guide our procedure.
Okay.
Any question about the...
Very nice work so far. Any comments from the panel? Looks very good. And can you tell us what size balloon did you use to dilate the atrial septum?
It's a 14
millimeter. Peripheral balloon, 14 millimeter.
Okay.
Okay, now we put the E-sheath in the femoral vein, and...
That's where we are at, guys. I think we can move on with the valve.
Okay, I leave Federico and Nedi to do the procedure. I will comment beside them.
Okay. So as you see, we also have left the balloon deflated on the second wire. This is in case we get stuck with our device and we need to ease crossing with the balloon. It's already inside the vascular system. We can just advance it and ease it through the anatomy. Ok, so morbida la guida, morbida.
We obviously put in pulmonary valves through the vein, and we're not so worried about French size. So sometimes we use a longer sheet, the core dry seal sheet, and we mount the valve directly onto the balloon, so you don't have to do any of the modification of the valve within the IBC.
Yeah. the other, the Sapien 3 valve can help us because it's a deflecting tip valve, so it will help us to cross the valve. Usually we use the 2-wire technique. I know that Lander, which is a stiffer wire, may be helpful, but in our previous case, we use this kind of technique, and absolutely is obviously is off-label procedure, but it's very helpful for the patient. We have a series of patients done, and they have very good result.
Could you talk us through the realignment process of the valve?
Yeah.
Now,
so we pulled the balloon inside the valve. Now we are doing the fine tuning, okay, which is fine at this moment, okay. She's neutralizing the force, okay, and putting this neutral. I think we are good. Now we need to hold the letter towards the bottom in order to have the deflection of our tip towards the septum. Now I think we can visualize a little bit better the septum. You see we have some wire prolapse on the body wire, which is not too bad at this stage, and I would definitely accept it. So we are advancing, and now I start deflecting the okay. Okay, you see it's advancing. Now I need to go coaxial. Store fluoro, please. We can go in the area of view, which is coaxial. Siamo sicuri che sia la guida? Paura che questo sia la Safari.
Patient tolerates very well.
In coaxial or the cranial.
You can see even the echo may be very helpful to position the valve. Okay.
Okay, centro bene.
Do you plan to place the valve 50-50 within the ring, or a little bit more into the left atrium, or a little bit more into the ventricle?
So I'd like to have it to have the valve ending at the radiopac rings of the Hankook valve. So a little bit, I'd say, more ventricular. But I mean, I accept any good advice from you guys.
And the echo may help a lot in this case. You can see the echo, and the position of the valve is absolutely.
Okay. Now she's pulling back very gently the catheter. I think this looks to be a good position. We hope that the valve basically realigns once we inflate it. Okay.
Probably.
Okay.
Can we also see the left ventricular outflow shaft and the relation of the valve to that?
Yeah. You mean in echo?
Yeah.
Va bene, come altezza.
Secondo me porto dentro.
Tiro
indietro. We have to pull back a little bit more. We have to remember to remove the body wire, you know? Poi dietro, vieni dietro.
Okay, I'm pulling back very gently. Okay, I think this is, what do you think? I mean, there is quite a lot of mess on fluoro because we see lots of rings there.
And it was so difficult to find the correct position to have a good access to.
Okay, I'm just removing the body wire. I think I really do not need this anymore at this stage. Store fluoro.
Io andrei ancora un filo indietro.
Yeah.
A little bit.
Sì, poco
push the
okay,
wire.
I'm just pulling very gently.
Vai con la valvola.
This doesn't look too bad. I will take a white fluoroscopic evaluation.
La prendesse, poi andrei fuori indietro.
What landmarks are you using to determine the valve position?
I'm trying to,
Guarda l'eco,
to align
Federico deve venire indietro.
Okay, I will just pull it back a little bit more.
Vai, vieni indietro.
Francesco, we have a comment from the audience. Alison.
Yeah.
Guarda l'eco, Federico, sei troppo giù.
Concept of pushing the wire, because this appears to be a very large safari in an elderly woman where you can injure the apex. So I think we resorted to using only extra small and trying not to push the wire so as not to create apical injury.
Vieni indietro, Federico, sei troppo giù.
Yeah, well, you know, I think Safari is a pretty safe wire in terms of, that's what we do every time when we do TAVI cases, we push it on the apex. I'm at the moment not too worried about that. I just seem to have a hard time finding a good visualization. I'd like to have the radiopac marker of the Hancock very perpendicular. Let's see if we can go more RAO, please. But you see, we are very in extreme position. It's not easy. Okay, but I think, what do you think, guys? Do you think this is a good position?
I think it's a little bit, I will pull back a little bit more.
Inclined to come back just a little bit more
Yeah,
with the valve
torna
and have the
indietro.
marker just in line with the ring. Yeah.
Perché te la prendi
Okay.
dentro.
That's your hang point.
Which is not bad. I think now I just pull it back. The marker is
Okay.
a little bit closer. I think we are good to go.
Meglio così.
Okay? Okay.
Ancora, tienila indietro.
So
però,
we need a
Attento
very
che
good
non se la
pacing,
prenda.
180.
Tienila in tensione. Keep it in tension, che non venga avanti.
Okay. Okay, so let's do this pacing on, please. Ok, pallo, vai, inizia a gonfiare piano. Vai, 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 sì, vai, vai, vai.
Tirala su.
No, ma va bene, va bene. Vai, 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 vai.
Tienila
vai.
teso,
Ok,
tienila in
I
tensione.
like it, very good. Vai, vai, vai. Vai fino in fondo, vai, vai. Ok, nice, very good. Vai in fondo, in fondo, in fondo. Ok, vai, 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 vai. Ok, perfetto. Ok, sgonfia. Ok, stop pacing, store fluoro. Okay, so you see I adjust a little bit the positioning where when it was inflated. Let's take a look again at the inflation. You see it pretty much self-centered the outflow towards the ventricle,
Okay,
and I very much like the position because we have the Sapien 3 outflow, which is
Around
ending at the level of the little rings, which is exactly where I wanted to land. Okay, I
But
think
the pressure
we can,
is recovered now, and we can measure.
tieni spinta la guida.
You can see the echo to see how
Okay.
nice is the new valve working. Now the leaflets are moving very well.
Okay, I think we can remove the catheter, leaving the wire in place.
And we can,
Okay,
we can put a pigtail in the ventricle because our pigtail now is in the aorta, and we can measure the gradient.
okay. Okay, I'd like to see, yeah, so we have two very tiny jets at the outer portion of the valve. I'm interested to have an echo evaluation of the gradient, if possible. A pigtail qui.
When do you consider to post-dilate if you have some paravalvular leak with mitral valve and valve?
That's a challenging question. I'd say that if the jet is non-tiny and mild or even slightly more, I'd be willing to consider post-dilatation. But I mean, I think this is very, very open to discussion. We have a 2.7 gradient, mean gradient
Quanto?
on that beat. The patient is in AFib, so she has lots of variable rhythm. But
So-
I think this is quite reassuring.
This is nice because we have a gradient of 3 millimeters mercury now, and we had a long discussion between us before to treat this patient because there is the doubt that was a mismatch. The gradient was due to the mismatch valve, but it was quite impossible with a 29 to have a mismatch gradient, and in effect it was very difficult to detect the mobility of the leaflet. But anyway, what we did was it's now we are so happy because
JR è una guida da campo.
the gradient is absolutely low. But this is
We just have a few more minutes left on transmission time, so maybe a gradient would be fantastic.
Yeah, so since I would like to avoid to recross the valve da cambio, I'd like to, maybe I can measure the gradient with a guiding catheter and with another catheter inside. So this is, I'm going to change this catheter. Let me just see if, okay.
Well,
you
anyway, we
you
can
don't have your
recross
seat
the.
in your LV. You have what's the aortic valve in place? It's another Hancock, is it?
That's another Hancock, yeah, which is okay, but you know, I needed some. Okay, so you see him. Okay, I'm just maybe gonna cross the Hancock, which is makes it just easier.
Before, not so easy. Anyway, we had
Dai
a
un-
very low
ok.
gradient, the echo gradient, so we consider not to spend too much time to cross the Hancock because the echo gradient is 3 millimeters mercury. Huh?
Vai in,
All the echo contrast was completely disappear.
Serve un
We had a
GR4
very
su questo
low,
guido,
a lot of echo contrast
no.
before. Now the echo
Anteroposteriore.
contrast is completely disappear, and so this is another characteristic that shows us that we did a good work with this valve.
But if you have,
Thank you,
if you have a few
Alessandra.
more minutes,
It's
I mean, we can cross the valve as you like, guys.
It's a great
We
pleasure.
have just one comment from the audience.
Okay, good
C'entra-
morning, Dr. Prigiona, cardiac surgeon.
Guida retta, guida retta, guida retta.
This one was my patient, and we discussed a lot if I have to perform the surgical procedure or not. And I was in
Leggero
favor
OS.
of percutaneous implantation valve, which is not so common in the relationship between surgeon and cardiologist. Thank you for your great job and the demonstration that indication was correct one. They discussed 1 week. There is no indication, yes, no, yes, no. The result demonstrated that the indication was very
Absolutely
correct.
perfect.
Thank you very much for your job.
Thank you to you.
don't get much
Thank
higher
you.
praise than that, so
Yeah.
you've
if-
done a fantastic job. Thank you so much for
I for,
explaining that wonderful
just to
picture.
say a
It's,
word, I have to
absolutely
thank you, Alessandro Frigiola, because I'm very confident that he had in our team. Thank you so much, Alessandro.